Welcome back, coders, to part 40 of our coding masterclass. So I recently saw a clinic lose thousands of dollars in revenue and face a genuinely brutal audit, all because they confused a standard commercial physical with a Medicare wellness check. It happens way more often than you'd think. Today we're going to untangle the complex, and let's be honest, sometimes super confusing rules of preventative services, the Medicare wellness framework, and the incredibly high-risk usage of Modifier 25. If you've ever been nervous about an audit when billing a sick visit on the exact same day as a physical, well, this explainer is built specifically for you. Let's get into it.
Here is our syllabus for today. We're looking at commercial preventative services, the Medicare wellness framework, Modifier 25 and audit defense, and finally, preventative counseling services.
All right, Section 1, Commercial Preventative Services, covering CPT codes 99381 through 99397.
Okay, let's set our foundation here. When we look directly at the CPT manual, a comprehensive preventive exam is absolutely not just a quick look over. It's the whole shebang. It has to include an age and gender-appropriate history and physical examination, anticipatory guidance or risk factor reduction interventions, and the ordering of any appropriate screening diagnostics or labs. It is a complete, holistic package of well care.
Now, your very first major rule of preventative coding is that you have to divide your code selection based strictly on whether the patient is new or established. You know the drill with our overarching E&M guideline here. A new patient is someone who hasn't received any professional services from the physician or another physician of the exact same specialty and subspecialty in that same group within the past 3 years.
So once you've nailed down that new versus established patient status, you literally just match them up to one of these exact 7 age brackets. As you can see, they span from infancy, meaning under 1 year of age, all the way up to 65 and older. So for example, if you have a 45-year-old established patient coming in for their annual checkup, that's a clear-cut 99396. It's a beautifully organized system, right? Well, provided you are actually dealing with a commercial payer.
Which brings us to Section 2, the Medicare Wellness Framework and the HCPCS G-code exception. Here's where things get a bit wild. Original Medicare essentially throws out those standard commercial CPT codes entirely. This is a very painful lesson for a lot of newer coders. If you try to bill a 99397 to Medicare for a routine physical, you are getting a flat denial. No way around it. Instead, we have to navigate Medicare's highly specific, totally separate G-code framework for wellness visits.
With Medicare, everything builds sequentially, based on the exact timeline of the patient's Part B enrollment. It's strict. You can't just pick and choose what sounds right. The code you bill is entirely dictated by how long the patient has been in the Medicare system and what specific visits they've had in the past.
Right out of the gate on that timeline is the IPPE, or the Initial Preventative Physical Exam. You probably know this as the Welcome to Medicare visit, which we code as G0402. Now, this is a strict one-time benefit that literally has to happen within the first 12 months of a patient's Part B enrollment. And take a look at these required elements. It's definitely not your standard physical exam. You've got to have a health risk assessment, you have to offer a screening EKG, do vision and depression screenings, and even include end-of-life planning. Then, once that patient crosses the 12-month mark in Medicare, they transition into the Annual Wellness Visit, or AWV, framework. They get one single lifetime initial AWV, that's G0438, and that focuses really heavily on checking for cognitive impairment and creating a personalized prevention plan service. Then, every year after that, and we mean exactly 11 full months after that initial AWV, they become eligible for the subsequent AWV, which is code G0439, just to update that personalized plan. Notice the big takeaway here, none of this relies on a physical, hands-on, head-to-toe exam. It's basically entirely cognitive and planning-based. Moving on to Section 3, Modifier 25 and Audit Defense when combining visits. Okay, we are officially entering high-risk territory. So what happens when a patient is sitting in the office for their scheduled preventive physical or Medicare wellness visit, but then they hit you with the classic, "Oh, by the way, doc, my knee has been killing me," or "My diabetes has been really uncontrolled lately"? Enter Modifier 25. This modifier is your best friend, but it's also a massive audit target. It basically tells the payer, yes, I did a preventive service today, but I also performed a significant separately identifiable E&M service for an entirely different problem on the exact same day. It's what allows you to compliantly bill a problem-oriented code like a 99213 right alongside the preventive visit.
But listen, you can't just slap modifier 25 on a claim and hope for the best. It absolutely demands proof. Your documentation has to clearly show a distinct history of present illness, a distinct exam, and distinctly separate medical decision-making for that specific acute problem. If the work overlaps too much with what you're already doing for the routine physical, it's not separately identifiable and you're going to fail an audit.
Your absolute best defense tactic in an audit is strict documentation segregation. Think of it like a wall. The preventative note handles the routine screening, while the problem-oriented note handles the acute issue. And here's a massive pro tip. If you are billing based on time for that problem-oriented EMM, you have got to ensure the time spent on the acute problem absolutely does not overlap with the time or the medical decision-making you needed for the preventative work. Keep them visually and clinically separated in the chart.
Finally, let's wrap up with Section 4, Preventative Counseling and Risk Factor Reduction.
Okay, golden rule time. This is a strict constraint coming straight from the CPT guidelines. These specific preventative counseling codes are strictly for patients who do not yet have an established illness related to whatever it is you're counseling them on, right? If they already have the disease, well, you're treating the disease, and that just falls under a standard EM visit. These codes are specifically for preventing an illness before it even happens.
When we look at these preventive medicine counseling codes, they range from 99401 to 99412. They're really distinct from your regular EM codes because they rely on exact time thresholds. For instance, 99401 is for approximately 15 minutes, 99402 is for roughly 30 minutes, and so on. You have to clearly document the exact time spent face-to-face promoting health and preventing injury if you want to use these.
And pay attention to the setting, because the code structure strictly differentiates between them. Codes 99401 through 99404 are strictly reserved for individual, one-on-one sessions. But if the provider is doing a preventative intervention for a whole group, say it's a healthy diet seminar for patients who are at risk of obesity but aren't obese just yet, you have to shift gears and use the group counseling codes, which are 99411 and 99412.
So what does this all mean for you? By mastering the distinct differences between commercial, physicals, Medicare wellness visits, and preventive counseling, you are directly protecting your practice's revenue. But before you finalize your very next visit, ask yourself, is your documentation truly telling two completely separate stories, or are you leaving yourself exposed to a painful audit? Keep your documentation airtight, avoid those claim denials, and don't forget to like, share, and subscribe to Decode Healthcare with Harshal.